Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to Going Antiviral Podcast. Today, August 15th, 2024, we are speaking to Dr. Timothy Wilkin, who is professor and chief of the Division of Infectious Diseases and Global Public Health at the University of California, San Diego. Dr. Wilkin is a prolific clinical trials researcher with a focus on prevention of HPV-related cancer in people living with HIV. He is an active investigator with the AIDS Malignancy Consortium, and his clinical expertise includes high-resolution anoscopy and ablative therapy of anal cancer precursors for prevention of anal cancer. Today, Dr. Wilkin is going to talk to us about issues in HPV and anal cancers with options for vaccination and screening. Tim, welcome to the podcast.
Thank you. I'm glad to be here. Looking forward to the conversation.
And it's good to speak to you now from sunny San Diego, I assume sunny.
Always.
Well, really glad to have you here. So let's just start at the beginning, just kind of a brief 1 to 2 minute summary of what is human papillomavirus.
Yeah, so human papillomavirus is a virus that is spread by skin-to-skin contact. The more you look for HPV, the more you find it. So there are hundreds of types of HPV that infect different areas of the skin. What we're talking about today are the types of HPV that affect the anal and genital area. And these types, some of these types have been associated with cancer. So most HPV comes and goes and you have no problems from it whatsoever. It's just really a small minority of those infections that can actually cause problems. So some of the problems are genital warts, and the more serious problems obviously are cancer that can develop. So cervical cancer, anal cancer, penile cancer, and also oropharyngeal cancer. Some types of oropharyngeal cancer are caused by these cancer-causing types of HPV.
So common warts that we can get on our hands, especially as kids, they're related, but they're not the same as what we're going to be talking about today.
Correct. So there's different types of HPV that can cause warts on the hands or the feet, but they're different than those that cause warts or disease in the genital area.
So a lot of the focus, especially with regarding to genital warts and precursors of cancer, focus on specific serotypes that are the bad serotypes. Can you tell us a little bit about what we know about those particular groups of viruses?
Yes, we have tremendous amount of data that tells us which types of HPV cause cancers. And so there's 14 types that we identify as high risk or cancer causing types of HPV. And they cause the vast majority of HPV related cancers. So the most important among those is HPV 16. So that alone causes about 50% of HPV cancers worldwide. HPV 18, another 20%, and so on. So among those 14 different types, there's the ones that the worst, HPV 16, and then there's the sort of next higher risk, and then there's a few that are sort of marginally associated with cancer.
So let me guess, if I were making an HPV vaccine, I might include those serotypes in there.
Yes, absolutely. So the current HPV vaccine that's available in the US and many places around the world is the 9-valent HPV vaccine. So that contains two types that cause warts, which are not related to cancer, and then 7 types, common types that are related to, that cause 7 types of it prevents against 7 types of HPV infections that cause the vast majority of HPV-related cancers.
Great. So that kind of sets the stage for the rest of the podcast here. We're going to get to vaccines towards the end, but let's start with just the screening and prevention modalities that we have in our clinics, we're going to focus, I think, mostly on HIV clinics or perhaps PrEP clinics that are seeing people who are at high risk for HPV, genital warts, and cancer. So maybe walk us through what you do in your practice, what you recommend as far as the best practices for screening and prevention in our HIV clinics.
Yeah, so just focusing on anal cancer, where there's been a lot of updates recently. Um, it Clinics that do it well generally rely on the primary care physicians or nurse practitioners or you know advanced practice practitioners to do the initial screening, which involves asking about any symptoms possibly related to anal cancer, so bleeding, nodules, pain, and then uh, obtaining a swab of the anus. And then that swab can be used for a couple different things. It can be used for cytology or pap smears, or it can be used for testing of HPV directly. Another important part of that is to do a digital rectal exam, because if you feel a mass, you can feel early cancers on the digital rectal exam. So if there's an abnormality there, or if the screening test, either cytology or HPV or both, are positive, the person's referred over for diagnostic evaluation.
Yeah.
And so,
The,
go
yeah,
ahead.
the DRE is what they call digital rectal exam. Some people
Yes,
see that in guidelines or an algorithm. What's a DRE? It's a digital rectal exam.
yes. So it is recommended, and it can find early cancers, which are very important.
Right. So does your clinic do both the DNA screening and anal pap with the swab?
Yeah, I think a lot of clinics will do reflex testing. So they start with a cytology result, and if it's more severely abnormal, say a high grade lesion on cytology, then they're referred directly over for evaluation. Um, a lot of people have a sort of it's called ascus or atypical squamous cells, and it you can see that with nothing going on, or you can see it with high grade precancers that are at risk for turning into cancer. So in that group, HPV testing can be helpful to sort out whether someone's really at risk for precancers or whether they're not and can just be screened again in another year or two.
Yeah, I think that's a really important point. Joel Plefsky out in San Francisco, but also Chris Matthews, where you are now in San Diego, were
Yes.
some of the leading pioneers of doing this type of screening. And one of the things I took away early on, and this is more than 20 years ago, was that there's a gradation of abnormalities in the pap smear that would either low risk or sorry, low grade to high grade type of things. Can you walk us through quickly that sort of pathology grading scale?
Yes. So cytology rubs off cells from inside the anus. And looking at those cells, depending on how abnormal they are, the pathologist will look at the nucleus or the center of the cell to see if it's enlarged or irregularly shaped, and look at the overall shape of the cells. And if it's high grade or more severely abnormal, then it's very likely that there are precancers present that need to be diagnosed and treated. For low grade lesions, you can often see that with other types of HPV infection, not cancer causing HPV, but other low risk types. You can see that with warts present. Generally, there's always high risk HPV also present, so HPV testing is not so helpful there. And then ASCUS, as we talked about, is a more equivocal or kind of on the fence. There could definitely be something going on, but often there's not. And so that's the group that HPV is particularly helpful. But for
And
people that have the high grade, you really expect high grade on biopsy that needs to be treated.
yeah, so when you were part of a major study through this AIDS malignancy consortium called the Anchor study, that basically evaluated follow up whether you did anoscopy immediately when you had lower high grade lesions, if I remember correctly, and then or watchful waiting and acting early was basically the recommendation. Could you just kind of summarize those findings for us?
Sure. So that study enrolled over 10,000 people or so, and all of them got samples for HPV testing and cytology, and all of them underwent this procedure, high resolution anoscopy. So that's the procedure where a plastic speculum is inserted into the anus. Vinegar is applied to make any areas of HPV damage show up. And then a special camera is used to really look at the details of the skin to look for areas that look like precancers. Those were biopsied. And the individuals who had these precancers were then enrolled into the trial. So that was about 4,400 individuals with these precancers. Half of them got treatment. So they would be treated initially. If there was still high grade disease or precancers, they were treated again and went on and on. The other group was watchful waiting, as you said, where they received biopsies every year and had a look every 6 months. And over following people for years, in some cases 8 years, 9 years, we looked at the number of cancers in both groups and found a lower rate of cancer in those who had been treated for their precancers. So that provided the strongest level of evidence that treating precancers actually prevents cancer.
Yeah, and I think all the clinicians that I talk to are really excited by those findings and want to do something. Yet, a lot of
Yet.
them don't have access to high resolution anoscopy and that type of thing. So they do the screening. Maybe they get a low grade lesion or maybe even an ascus, but whatever. And they don't have anyone to refer to. They don't have anyone in their clinic. And that seems to be the biggest barrier to implementation of the guidelines, if you will, to follow the results of the anchor study. What do you say to those folks?
Um, First of all, that's absolutely the biggest barrier right now. High resolution anoscopy is the centerpiece of anal cancer prevention. You have to have that procedure to really prevent cancer at this point. And so basically, you can't just refer to a surgeon or a gastroenterologist and expect adequate or appropriate treatment. So generally, clinics and health systems have to cultivate that talent within. I would say the easiest people to really pick up these skills are actually gynecologists because they
Mhm.
already learned cervical colposcopy. It's a very similar procedure. And they have the equipment and everything set up. And I would say with widespread HPV vaccination, the need for colposcopy and LEAP and all the services for cervical cancer prevention should hopefully decline. So it would be great for that skill set, that group of people to pick up anoscopy to really increase the capacity. That being said, we people learn anoscopy just from the start. So there's a lot of physician assistants, nurse practitioners, primary care doctors, infectious disease doctors, anybody. There's coursework, didactic coursework to really learn the concept and see thousands of pictures. And then it's really ideally a proctored evaluation learning period where you have somebody who's experienced watching you start the procedure, providing advice and troubleshooting. And then it takes 50, 100 cases before people really become proficient. So it takes a long time. I've trained several people. It's a big commitment to train people. Not everybody is actually able to physically do it very well. So it is challenging, but fortunately, we've done it at a pretty large scale for the anchor trial, and there's a national organizations, the IANS group, that ASCCP, that have a lot of great training materials.
Really important because you sort of hit the stop codon, if you will. You can't move further unless you have that critical piece. And like you said,
Yes.
the similarities are between cervical cancer screening and anal cancer screening are like right in lockstep. So I think that's a great suggestion to go to maybe gynecologic colleagues or even nurse practitioners in the GYN clinics and see if they're interested in being trained in helping out,
Yes.
setting up an anoscopy clinic within the HIV clinics, especially those that are larger HIV clinics. So believe it or not, we're about halfway through, and we've covered a lot of territory. But I would like to shift gears a little bit to vaccination. So the
Yes.
history of this vaccine has been available for quite a while, um, and yet uptake seems to be a bit of a barrier here. But just describe what you already did a little bit about the non-valent vaccine, but with that available to us now, um, what are you recommending? And we have to involve the pediatric docs and nurse practitioners to help us here. But what is the current recommendation for use and implementation of the vaccine?
In the U.S., it's recommended for everyone. Ideally, it's the recommendations are age 9 to 12 or 9 to 13 to initiate the HPV vaccine series. It's critical to initiate HPV vaccine prior to any sexual activity. And I think one thing we're learning is there are some data that even just a single dose is really helpful. So if you start early, the current recommendations are you only need 2 doses 6 months apart. It's an amazingly effective vaccine. There have been cohorts that have been followed out for decades, and basically no vaccine failures. Um, HPV
So,
causes
so wait a minute. That
5%.
means people that have gotten this vaccine, boys and girls,
Mhm.
they followed out for a couple decades. No cancer in those populations, as
No
far as you can.
cancer related to the types of HPV that are contained in the vaccine. I mean, it's
That's
amazing. Yeah.
yeah.
And genital warts, like in Australia, it's almost a thing of the past because they've had such widespread vaccination, and they just really don't see genital warts anymore. And
Yeah.
we focus, obviously cervical cancer is a huge problem worldwide still, and but in the US, actually, it's more common for people to get HPV associated oropharyngeal cancer. And I
Mm,
think people have maybe have relatives, people they know that have gone through those surgeries and treatments, and they're
yeah.
they're really difficult. And
Yeah.
we don't have a way to screen for it, and are really the only way we can prevent that really difficult cancer is with HPV vaccination.
Yeah, I remember even early on, because before I even went to medical school, how lay public folks would come up to me and knew I was interested in medicine and say, "How come we don't have a vaccine against cancer?" Well, we do, but
We have we
it's
have
the
we have
uptake.
two, right? Hepatitis B as well. Amazingly
Exactly.
effective for preventing cancer. Yeah.
So we really need to push hard. What do you think the uptake is? I know it's regionally different, but in general in the United States for giving HPV vaccinations now?
Um, I mean, to complete the series on time, I mean, some studies have been in certain areas as low as 30 or 40%. I think overall
Mm,
it's maybe about 50 or 60%. Keep in mind, there's other countries like Rwanda where they're just vaccinating girls, but they're at 95% coverage.
mhm.
So it is a really huge issue and an area of research about how do we address this misinformation about vaccination? How do we really engage people in the vaccine programs?
Yeah, the one of the things that's happening internationally, and I'd like your comments on this. You mentioned the series of two vaccinations 6 months apart, but just kind of almost as a harm reduction approach, a number of middle income, lower income countries are just approaching this with a one shot without the
Yes.
follow up. Are there enough data yet to endorse that? I mean, I realize they're doing it because of necessity, but um, do you think that's going to work?
So there are really high quality data that suggests that it works well. I would say we don't have the extended follow up of 10 years, 15 years to know how long that protection would last. So if you go to an HPV conference, it's always really, really controversial. I would have to say, if I were, if I had a million doses of vaccine to give, I think giving a million different people a single dose would have a bigger impact than half that number getting two doses. So I don't know that for areas that have more resources, I would probably want to wait for longer term
Sure.
data. But in areas where they have to make difficult choices with their healthcare dollars, I could easily understand how you would choose single dose.
Yeah, and then you think about it. Let's say we have a country of hypothetically 15 million people, uh, children that need vaccination. If you vaccinate 14 of the 15 million children, even just with one, if you get enough protection over the next 20 years, then that concept of herd immunity that we heard ad nauseum sort of during COVID, but that herd immunity could really extinguish the cervical cancer in that country theoretically.
Yeah, there is good data for that. I mean, there's lots of modeling that's would predict that. I think in Australia, where they've had good but not perfect vaccine coverage, they've had a reduction of some of the HPV events more or greater than the proportion that's been vaccinated. So I think there are data to support that.
And you mentioned Rwanda, and let's compare and contrast Rwanda to, say, Australia. Rwanda's doing only girls. Australia, I'm assuming, is doing boys and girls like we are. Um, what what's driving this in Rwanda? Do you think, without getting too political here, but because it takes two to tango, right? And it can be transmitted men to women and vice versa. Um, is it just because they're only focused on cervical cancer there, or what do you think is happening?
Yeah, I mean, I would want to fact check myself to make sure what their current vaccine policy is. I'm thinking
Sure,
of information from a couple of years ago, but in general, many countries just vaccinate girls. There are a lot of models that suggest that that would really drive down cervical cancer rates, and as you mentioned, the herd immunity that would also protect boys and men as well. Um, I just I don't know that there's enough long-term actual data to suggest whether that really works. And and certainly there's other types of cancer like oropharyngeal cancer and that would need to be considered. So I think again, that's a tough choice for countries that have limited amounts of
sure.
healthcare dollars, whether they vaccinate girls more broadly or uh, vac- or choose to include boys. And so that's part of the reason why a single dose is really attractive, because you could probably, you know, use some of those funds to vaccinate boys as well.
Get twice as many people.
Yeah,
Yeah. So I didn't mean to throw Rwanda under the bus. They do a lot of things really well
they
there. That's for
amazing.
sure.
Yeah,
Yeah, and like you say, they may have changed policy, but the ideal would be
but
to
it's
do.
I do want to say that that's a very reasonable approach to just vaccinating girls.
Yeah,
In yeah.
yeah. So but the concept is, I think, bringing this home at this point. Um, everyone, American Academy of Pediatrics, et cetera, are recommending HPV vaccination to children starting at as early as the age of 9. Um, recommended ideally two doses to both boys and girls. And the future is really bright if we can implement that. I mean, the usual barriers to vaccination exist, but boy, this is a compelling story that we should really be pushing extra hard on in terms of getting uh, uh, engagement of really the entire country. And a lot of folks, I mean, here in Alabama, there are counties where the uptake is very low, and we have targeted education, not just to the parents, the doctors, I think, get it, but also the schools and other things to support. And we're going to need to keep that up. We're about out of time. I'll just turn it back to you to summarize what your thoughts are about the next 10 years with what you hope to see in the realm of HPV.
Yeah. So as far as anal cancer screening and cervical cancer screening, I think we're going to learn a lot more about the best way to screen for those cancers and the best ways to prevent them. There's a lot of exciting things going on about novel treatments, so HPV immunotherapeutics to give us some different options to treat HPV disease. And I think there's new HPV vaccines that are being investigated that have even more protection. So instead of 9 types, maybe 13, 14 different types. And hopefully we'll learn how best to communicate the benefits of HPV vaccination and get better strategies to really reach everyone with this vaccine. This is a preventable cancer. And we really need to step up our efforts in getting vaccines into arms.
Very well stated. And we've covered an amazing amount of information in just a short period of time, but I think you really nailed it, Tim. Just a wonderful discussion we've had. So thank you very much for joining us today. And we'll try to put some of the references attached to the podcast so people want to read the primary papers, they can. Thank you again for being with us, Tim. It was a great job.
Thanks for having me.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.